We've presented some interesting data for the efficacy of Spiriva in asthma patients. So this is a very recent approval from the FDA. We'll be launching sometimes early in 2016. And what we have for the first time in many years, I think it's 10 years, is a new treatment modality for the management of asthma. So it's a new mode of action in asthma, a LAMA rather than the usual LABA, an ICS, and other therapies that are used to control the disease. Again, the FDA have given us a very broad label, which leaves the decision very much up to physicians about where Spiriva should be used for treating these patients. Our data is in patients who are taking at least inhaled corticosteroids, and we would advocate that that is the appropriate place for the use of tiotropium. But physicians will make decisions based on what's best for their patients, and I think an informed patient would be able to help a physician choose the right way forward. And as a physician watching how physicians behave, it will be interesting for me to actually see where physicians believe is the best place to use Spiriva. But certainly what we have now is a non-steroid treatment that can be used in combination with an ICS, in combination with a LABA ICS, and I think that's very exciting for patients. The side effect profile is the same as it is for Spiriva when used in COPD. So the main side effect would be dry mouth and other anticholinergic type side effects. So Spiriva is a bronchodilator, so it opens up the airways. Again, it's for symptomatic treatment, so it's for patients who are uncontrolled. And patients are uncontrolled to a surprising extent with asthma. Some figures, there are 25 million asthmatics in the US, and some figures suggest that there could be as many as 50% of those who are not controlled. So this is a therapeutic option for those patients. And as I say, it works by opening up the airways. Multiple reasons. Some of it's down to patient concordance, compliance, adherence to their drugs. Some of it's due to misdiagnosis. There is also a reluctance sometimes to be more aggressive with treatment. There are concerns with inhaled corticosteroids, particularly in younger patients and perhaps the elderly, where there may be a downside to giving those drugs. But I think it's about physicians, particularly in primary care, being very mindful of their patients and their symptoms, and recognising that they actually do still have symptoms, because they often do not volunteer that, and actually you have to get to the answer. You have to find this out by probing. So have a conversation with your patients. Make sure that they really are as well controlled as you think they are. I would hope it has a very strong place for doing that. I think as physicians become more familiar with using the drug, I would expect be using it in more and more patients. And if patients find that they get the benefits from Spiriva that we would expect them to get, if they are comfortable with the Respimat inhaler, which we believe they will be, then we would hope that that in itself would encourage adherence and persistence in terms of taking therapies. And if we ensure that we're asking the right questions, ensuring that patients' symptoms are being dealt with, that patients are going to take their medications, then that's a big step in the right direction to controlling this condition.